Hi, everyone. We're on to our second video for our second lecture for week 7, module 7. Last time we were talking about diagnosis of viral infections, and in this one, we're going to talk about how we can either treat or prevent viral infections. I'm going to go ahead and bring us to our PowerPoint. So today we're going to talk about antiviral treatments. The learning objectives from this, the first one is that I'd like you to be able to list the challenges of antiviral treatments. So what is hard about treating a viral infection in humans? And we'll talk about that. I also would like you to differentiate between what we call passive and active immunity. And I'll talk about sometimes we can actually treat people in what is called a passive way. And then we can also do prevention using what is called active immunity. We are going to talk about vaccines in this particular lecture. I'd like you to know the difference between what are called live attenuated vaccines or dead inactive vaccines. And generally, we have certain populations that we can treat with either of these. The last thing that I want you to think about is to know the main targets of any of these antiviral treatments. So for some of the drugs, you should know what we're actually targeting with the viral infection. So with that, I'd like to talk about what the challenge is. Why is it so difficult to treat viral infections? So even the common cold, we know that we get the common cold and there isn't really any way to cure us. We just can treat the symptoms. So the biggest challenge is that drugs that would specifically target viruses are very difficult to design without them causing some sort of damage to our cells. Remember, the virus gets into our cells and replicates there. And so really going after it often will cause damage to our cells because they're inside of our cells. The drugs, though, that we do have developed can be classified into 5 main groups. And this really is based on the replication cycle. So this is a good review of that replication cycle of viruses, but basically we have drugs that are designed to either block attachment of the virus to the host cell. Maybe we can target the penetration. So even though it attached, stop it from coming into the cell. We have drugs that can affect whether or not it becomes uncoated. So that nucleocapsid is removed, that capsid gets removed. And then there's other drugs that can stop synthesis and assembly and even release. So keep in mind, these aren't really targets of a specific thing about the virus that we're attacking. Rather, we're blocking one of the steps of replication. So it wouldn't really be curing it, but stopping it from infecting more cells or more people. There is a 6th category now of drugs that will stimulate part of the immune response that works well against viruses. So remember, we talked about interferons, which have the ability to warn neighboring cells that are not yet infected of impending infection. And so there are drugs that are being worked on to get the interferons higher in the body. Antiviral drugs are mainly effective when the viruses are actively replicating. So why is that? It's because the targets are actually the replication cycle, not a structure of the virus. So some of the main classes that we have are what are called nucleoside analogs. These are really great about stopping replication of the genome. So viruses have to replicate their genome, and nucleoside analogs actually stop that from happening. So we target, in this case, this would be the synthesis step, right? When they're trying to make lots of copies of their genome. The other place that we can affect them is any enzymes that they need to integrate their genome, to make any of the capsid or the genome. If we can inhibit those enzymes, it stops them from replicating. Some things to keep in mind, though. We talked about the fact that some viruses can be latent, meaning that they can kind of go into hibernation in your body and you don't have symptoms. Those are very difficult to treat with antivirals. Most of the antivirals to date are against the human immunodeficiency virus, or HIV. We have some medications that work against certain herpes family viruses, and then hepatitis viruses and influenza. There are new antivirals that have been made for SARS-CoV-2, but we're really early on in that because it's such a new disease. The other way that we can treat you if you have an infection is to do what we call passive immunity. So I'm going to go to my whiteboard and just briefly explain what I mean by passive and active immunity. So when we think of immunity, there's kind of a way that we can divide this up, and we can say that you can have passive, and that sounds weird, but that means that your immune system isn't what is actually giving you immunity. We can have active, and in this case, I like to think of this as host immune system is activated. So think about that as adaptive immunity is fighting. Okay. So we'll talk about what I mean by that. And often this is because we have been vaccinated. So vaccines. Passive immunity is a little bit different. And passive immunity means that maybe you're sick with something like SARS-CoV-2, but your body isn't responding in a way that you are able to fight it off. We can actually give you in the hospital or in a medical setting antibodies to fight it. So in this case, host immune system is what I would say is inadequate, meaning that it is not fighting off as well as it should. And so antibodies are given in medical setting. So if any of you remember or have heard about people, I think it was the ex-president Trump that had this when he had SARS-CoV-2, they talked about giving him monoclonal antibodies. And that's often what we call these is monoclonal, meaning that they're all the same, but they fight the same thing. But basically that we can design these antibodies that we give to somebody who is not able to fight off the disease on their own or is not doing a well enough job that we are sure that they're going to pull through. We can give them monoclonal antibodies. And if you remember monoclonal antibodies, when we have antibodies in the system, this aids in phagocytosis. It helps with inflammation. It brings in lots and lots of immune cells like phagocytes. So this can really help you fight it. But in this case, it's not your body that made the antibodies. It's antibodies we gave you in a medical setting. So I'll go back and talk about that again on the PowerPoint. So with passive immunity used today, as I said, we have treatments for hepatitis A infections, but also SARS-CoV-2. And in this case, we're giving somebody treatment with antibodies that we took from somewhere else and are giving them. But keep in mind that when you get treated with this, your immune system likely will not protect you long-term or become immune because that's not what fought off the disease for you. Now, active immunity, as I said on the board, means that your adaptive system has started fighting. And remember, adaptive immunity has memory. So this can either be caused by a natural infection, you get sick, you fight it off, and you have those memory cells for the next time you see it. Or if you have a vaccine basically exposes your body to an antigen. Your antigen then, your body builds up antibodies to fight it, and it also tucks away memory cells. So if you see it again, you could fight it off. And so vaccines and some infections can cause immunization, meaning that the next time you face this particular virus, you won't get sick. So for example, an unvaccinated person who recovers from the measles virus naturally would be immunized, or a vaccinated person for measles would also be immunized. Active immunization will give you long-term protection. Keep in mind, there is a caveat to that. RNA viruses like influenza and SARS-CoV-2 change so quickly that we have new variants that we don't really see long-term immunity because it changes from the immunity that we had against it. So it's a little bit more complicated than just you're immune or you're not. But for many of these, like measles, we can have lifelong immunity. So let's talk about what vaccines are. Traditional vaccines fall into two big categories. We can have either what is called a killed or inactivated vaccine or a live attenuated vaccine. And the way that we think about this, the way that these were traditionally done, is that we would take a pathogenic virus, so let's say this is SARS-CoV-2, and we take it out of the patient, isolate it, and we start to grow it in human cultured cells. So we grow lots and lots of it. Then we use this cultured virus where we've grown lots of it, and we use it to infect monkey cells. And we grow it in this cell culture for many generations. And what happens is this virus begins to change and acquire mutations that allows it to grow well in monkey cells, but not in human cells. And what we can do then is we can take that then and give it to humans. It doesn't make you sick, but it creates an immune response because our body still sees all of these little spikes on the outside as foreign, and they then mount an immune response and store those memory cells. So let's talk about the difference between killed or inactivated and live attenuated. What are the pros and cons of each of those? So with inactivated or killed vaccines, the thing to keep in mind is if this was a virus or a bacteria, these cannot reproduce. They have been treated in some way so that they are dead or inactivated, even if they get into the body, but they still have those antigens on them that our body recognizes as foreign. The nice thing about these, they're safer than live vaccines in that they can't mutate. They mainly induce antibodies to be made by your humoral immune response, so your B cells. And in general, they're usually a whole inactivated pathogen, or maybe we've taken subunit, like just the spike proteins, and used that. The benefit of this is that these are very safe for people who have immunocompromised bodies. So if they're on drugs that have compromised their immune system, or if maybe they have HIV, this is something that's very safe with them. In addition, they're stable at room temperature. So if you think of places that are more rural or less developed and doesn't have access to keeping things cold in a fridge or freezer, they have a shelf life, right? They can be at room temperature. The drawback is that often you have to have multiple shots. You have to have multiple boosters in order to have an immunity to whatever it is that you are being vaccinated for. The next group would be what we call our live attenuated vaccines. These ones mean that they are treated in some way that they can no longer cause an infection in a healthy individual. But because they can replicate and stay in the body longer, the immune response that they mount, the body mounts against them, is much more long lasting. So these contain altered pathogens that don't cause disease, but are still infectious. The benefit is they stimulate a very strong immunological response, and it has a very long-lived memory. The drawbacks, though, are that we can't use these in immunocompromised hosts because if their immune system is very weakened, these could actually cause an infection in them. In addition, because they're live, they can mutate and possibly become infectious again. The last thing is that they have to be refrigerated, so you have to have the infrastructure wherever you're using these, where they can be kept cold before they are used. So when we think about this, the challenges that we often see with traditional vaccines is that not all viruses can be cultured, meaning that it's difficult to grow some of these. Some of them may be really difficult to inactivate or attenuate effectively, so we may not want to use them if we can't make sure that they're not going to cause disease. And some of them will revert back to their infectious form, and we don't want to make somebody sick with it. Lastly, there's shelf life limitations, right? They'll only last so long. This is not something I'll test you on, but in case you're curious about any vaccines you might have had, this tells you what type of vaccines they are, whether they're inactivated or live attenuated. And that's kind of something that you can keep track of, see how you feel about those. If you have questions, please let me know. I'm happy to answer any questions on vaccines. I also want to talk, though, about new generations of vaccines, and this is especially interesting, especially with SARS-CoV-2. We have a new generation where we are using nucleic acids, so we can use what is called recombinant DNA methods. These are very safe in the sense that they're just parts rather than the whole virus. So there's no way that it could cause an infection because it doesn't have the entire virus there. So often what we can do is we can use subunits. So maybe we use capsomeres of the capsid to get an immune response with a vaccine. We can use peptides, which is just another word for protein. So maybe spike proteins that we've removed from the virus, we can give that to somebody and that would elicit an immune response. Sometimes we use what are called live vectors or reassortment viruses, meaning that we use harmless viruses, but we put a gene in it that can make the protein for the virus that we want to protect you against. And then the last one, and this is probably one that we're all kind of familiar with now, is these DNA or RNA virus vaccines, meaning that we take a small part of the genome, perhaps for something like the spike protein, and when we use that RNA, it will get your cells to make the spike proteins, no more of the virus, not any other part of the virus, but the spike proteins, and then our immune response will come after that. So with these subunit vaccines, some of the ones that we see is that these antigenic fragments or parts to the virus will stimulate an immune response. So as I said, we can do subunits, so just parts of it. We can also do what are called toxoids. So if it's a virus or a bacteria that produce toxins, and that's really what harms us, we can give inactivated toxins so that you're immune to it. I do want to briefly talk about those nucleic acid, primarily about the RNA ones when we think about SARS-CoV-2. We can actually inject naked DNA or RNA, and what that does is, remember, that can produce a protein. It has the recipe to make a protein. And so, for example, the SARS-CoV-2 vaccine, the mRNA one, has the recipe to make spike proteins. It doesn't make the capsid, it doesn't make the genome, but it'll make a bunch of those little spike proteins. And what ends up happening is when we give that vaccine, your cells look at that mRNA and think, oh, I should make this protein. So it makes a bunch of these spike proteins, and then the immune response looks at that spike protein and says, huh, that looks foreign. It doesn't look like one of our proteins. And it tells the adaptive immune system, the humoral and cellular, to go attack it. And remember, it'll attack it, clear the body of it, but it tucks away those memory cells, which means that vaccine that didn't give you the disease protects you, so the next time you see it, you have a secondary immune response. You're much more protected. The last way that we can do this is what we call a recombinant vector vaccine. We can take an avirulent virus, and that's just a harmless virus, something that won't cause disease in us, or a bacteria, and we can genetically modify it so it has genes that will make the antigen. So it's kind of like a Trojan horse that would have the recipe to make those antigens and get that immune response. So you really want to think about, and I'll go to the whiteboard to talk through this, but you really want to think about, when we think about vaccines, vaccines are basically tricking the body. So if we talk about vaccines, vaccines are a way to trick host body or host immune system into thinking there's an infection. And what happens, and you probably already know this if you've had vaccines, is that your body kind of freaks out, right? You might have a low-grade fever. You might be kind of achy, feel kind of flu or kind of cold-like symptoms for a day or two. And that's because the vaccine has an antigen in it that makes your body think it's under attack, and your body freaks out. It does fever, it does inflammation, it recruits the whole adaptive immunity to come along with the T and B cells. But you're not being attacked by the virus, right? So what you get is you get an immune response. And remember, with the adaptive immunity, one of the key things is that when this is stimulated, one of the ultimate things that we get out of it is we get memory T and B cells. So basically what you're doing is you're tricking your body into thinking it has an infection. It then freaks out, tries to attack it, and it stores these memory and T and B cells. And what that means is that then when you actually are exposed to the disease, maybe 6 months or a year later, your memory T and B cells can start working immediately. And often you won't even know you've been exposed because you won't have any of the illness. And so that's really the beauty of vaccines, is vaccines take advantage of the adaptive immune system, or adaptive immune response. And so this is kind of why vaccines are so helpful and are such a great way to protect ourselves. So with that, I'll go back to our PowerPoint and we'll finish up this slide show and kind of talk about it. One of the things that I do want you to keep in mind, though, that we do have to be careful with people who are immunocompromised. So humans that are immunocompromised, whether they're transplant patients who are taking immunosuppressive drugs, or maybe they're HIV infected individuals, or often cancer patients are immunocompromised. We don't use any of the live attenuated vaccines. We only use the dead or inactivated because we don't want somebody who has a compromised immune system where they could possibly get an infection. You should keep in mind, though, that if you're an immunocompromised host, even with a dead or inactivated vaccine, often you will not be able to mount an immune response or get as strong of an adaptive immunity as somebody who has a healthy immune system. And that's why it's so important for all of us who are healthy to get vaccinated to protect those that can't really mount an immune response. And we'll talk more about that in next week's lecture. So some things to think about, though, with vaccines. There used to be additives that were added to vaccines that we no longer do because we know that they cause problems. But some vaccines do have additives that people are allergic to. Now, that's different than an adverse effect to the vaccine. That would be an actual allergic effect. And usually that's something that it is added to either prolong the life of the vaccine or make it so that it has a more stimulating effect on the host. The other thing that probably most of you know is we have side effects, and that's because your adaptive immune system has been kind of poked or prodded when you have a vaccine. And so your innate and adaptive immune system responded. That makes us feel kind of crappy for a day or two. The other thing that can be issues is the way that vaccines are delivered. So there are new ways that we're looking at delivering vaccines. This would include things like nasal sprays or skin patches or even time-release pills. Lots of people are scared of needles, don't like them. But also needle and syringes are difficult when we look at a global vaccination program. It's hard to get enough needles and syringes throughout the world, especially in developing countries. So if we had something that was just a nasal spray or skin patch, it might be easier. So one of the things I want to talk about too is the challenge of vaccines. Vaccines are not a big money maker for companies because if you go get vaccinated, you get one dose and then you don't pay to that pharmaceutical company anymore. So there are very few numbers of vaccine companies because for the most part, making daily pharmaceuticals, so let's say high blood pressure medication that somebody has to take every day, is much more profitable or money-making than a vaccine that you only have to have once or 3 times in your life. So there are very few companies that want to do vaccines when they can make lots more money doing drugs. And so the other thing is that we see that the majority of individuals who are in need of vaccines are children who are in countries that can't afford to pay the drug companies for this. And so UNICEF is one of the major consumers who pays for vaccines, but a lot of drug companies don't want to spend kind of research dollars and their facilities on it because they just don't make back the amount of money they can through drugs. Now, with SARS-CoV-2, with it being a global pandemic that hit everybody at the same time, that was a much more quick way to get vaccines because we had the whole world working on them, and there were lots and lots of governments who were paying money to the pharmaceutical companies. But in general, it's not typically profitable for pharmaceutical companies. That brings us to our checking in. So remember, pause here, write down the answers or say them out loud, and then you can come back and I'll give you the answers to the questions. So our first question is, why are viruses a challenge to treat? Viruses are a challenge to treat because they're intracellular pathogens. They replicate inside of our cells. And so when we try to target them, we could be hurting our cells. Question number 2, how do vaccines utilize the adaptive immune response to protect hosts? Remember, vaccines trick the adaptive immune response to make these memory cells for this given disease without you actually getting sick from the disease. So that's a really cool feature of vaccines. Number 3, what is the difference between attenuated and inactivated vaccines? So attenuated means they're able to replicate And we think of them as not harmless in a healthy host. Inactivated means even in the host body, they can't replicate, and so they're safe to use with those who are immunocompromised. Name one type of new generation vaccine. We can think of subunit or those nucleic acid vaccines, the RNA or DNA vaccines. Why do drug companies prefer to make medication rather than vaccines? Medication often has to be taken more than once or twice, so they can make more money by having people taking a drug over many, many years rather than just a one-time dose of vaccines. Hopefully that was helpful. We will get back to, or we will be talking about immunity a little bit more next week and talking about how we as a community can protect people from viral infections. So let me know if you have any questions. Thank you for watching.